Hi, welcome to the webinar today, Compliance Cliffs, Navigating the End of Telehealth Waivers and Shifting Reimbursement Rules. We're happy to have you join us today. We are co-sponsoring this webinar today between MedUSA and First Healthcare Compliance. Our agenda for today, and Robin, you can go to the next slide if you have it. There we go. So we're going to do some quick introductions and I'll review some housekeeping with everybody. And then Robin will jump into telehealth first, some updates on the One Big Beautiful Bill Act, prior authorizations, and Medicare Advantage. We will leave time at the end for Q&A as well, and I'll kind of walk through how we're going to do that in a little bit. So just for introductions, I'm going to start by doing some company introductions. I'm Brianne Meadows. I'm the president of First Healthcare Compliance, which is a part of Panacea Healthcare Solutions. And just to introduce a little bit about First Healthcare Compliance, we were founded in 2012. We provide comprehensive compliance solutions to healthcare organizations nationwide, including private practices, hospitals, and billing companies. Our all-inclusive online platform offers a centralized, user-friendly solution for managing compliance programs, education, and documentation. As a trusted compliance partner, we focus on enhancing education, operational efficiency, and regulatory excellence. Our tools and resources support adherence to HIPAA, OSHA, HR regulations, and laws related to fraud, waste, and abuse. We also deliver expert-led webinars like we're doing today, training modules, and resource libraries designed to promote client success and continuous education. And then I'll tell you a little bit about MedUSA. So for more than 40 years, very long time, MedUSA has partnered with medical practices nationwide to help them reach new peaks of performance and profitability. As a trusted leader in revenue cycle management, medical billing, and provider credentialing, MedUSA delivers tailored solutions that streamline operations, improve compliance, and maximize reimbursements. By combining deep industry expertise with personalized service, MedUSA empowers healthcare organizations to focus on what matters most, delivering exceptional patient care. So we'll do speaker intros. I'm simply the moderator today, so I have the easy role. Again, I'm Brianne Meadows. I'm president of First Healthcare Compliance, and also at Panacea Healthcare Solutions, I am the president of Revenue Integrity Solutions. I am a rev cycle and finance person by trade. I've spent the first half of my career on the provider side and the second half on the business partner side. But the real star of our show today is Robin Johns, who I'm super excited to be presenting with today. Robin is the compliance officer at MedUSA. Robin has worked in healthcare compliance and practice management for over 30 years, beginning at the front desk and working through almost every aspect of practice management. She's worked with a wide variety of specialties and practice sizes and has held positions in billing, denial management, payer audits, payer enrollment, and operations management. She also focused on the areas of ethics and healthcare compliance throughout her career. Robin enjoys presenting and training on practice management, operational efficiencies, and healthcare compliance. She is a relentless learner, and with ever-changing regulations, payment modules, security threats, and healthcare methodologies, she is never bored. So again, thank you for joining. Just a few housekeeping items. If you have any general questions during the presentation, just anything that's not related to Q&A, you can use the comment box. We will have somebody monitoring that if you have any general questions about today's presentation. If you do have questions for Robin, please utilize the box with a question mark in it and submit your question there. We will review those and ask as many as we have time for today. If we run out of time, we will answer them and send them out after the presentation concludes. And we will have polling questions. There are some CEUs offered, one CEU offered with today's presentation. You do need to answer 3 of the 4 polling questions throughout the presentation in order to receive your CEU credit. So I think that is all the housekeeping. I'm going to turn it over to Robin to get into the telehealth updates. I know she's been working on them since right up until right before the presentation, so they will be timely.
Yeah, like we said, we're certainly not bored. Things may change after our presentation just later today. So hopefully we're up to date at the moment, and we'll try to keep everybody up to date as we go forward. But a lot of it has been going on. A lot of the changes have affected telehealth. So that's going to be our focus here for the first little while. The first telehealth cliff, the first cliff that we faced was actually September 30th. We all know at this point that we've fallen off that cliff essentially and been in the government shutdown since September 30th, essentially October 1st at, 1 a.m. or 12:59, I guess. And, but we see the light at the end of the tunnel for that. So just a quick update on where we are with that, because it does affect what we can do with telehealth, right? So at the moment, the Senate has passed a continuing resolution. It's currently pending a House vote, which is set to probably happen later on today. They're saying probably around 7 p.m. Eastern time. So there is the possibility that there could be changes to what the Senate passed. There's not a lot of talk that that's likely. So this is what it contains right now, and we're anticipating it should probably stay pretty much the same. So we all know it's going to fund the government, but only through January 30th. It does reinstate all of the waivers that expired at the end of September, and we've had on hold for the last 43 days or whatever it's been. So it does reinstate all the telehealth waivers, the hospital at home, and the 1.0 floor for the work GPC is what we usually call it. So, and that's, so anybody that where your geographical pricing is raising it up to 1, but any payments you've received in the last 40 some odd days have been slightly lower, but that's supposed to be reinstated. So they're also rehiring any federal workers, all that were furloughed, and anybody that was fired or laid off during that time has to be rehired according to this deal. And it guarantees back pay for all of those federal workers. As most of us know who are paying attention, it does not extend the enhanced ACA subsidies, and that will kind of affect as we go into one of ways to maybe prepare our practice, especially for the big beautiful bill. That will also be part of it. So now we have a new telehealth cliff pending, which is January 30th of 2026. So that's when all of these things will expire again. So some of us may be very familiar with what happened on September 30th and what we've had to deal with since then. Some of us may be less familiar because we just kind of hoped it was all, we kind of held our claims or assumed that Medicare would go back and pay them. So hopefully we can give you a little bit of detail and you can be prepared should it happen again at the end of January, or if any of it does change. So the things that came into play, they're currently actually in place, and they supposedly will go back, be retroed back to the beginning of October, dates of service October 1st and forward, and be effective until January 30th, may expire on February 1st. The geographic requirement is the first one, and that is simply that the patient's location, their originating site, has to be in an approved geographic location. And here's the list of what those are. Typically, they're going to be more rural areas, or sometimes those specific Medicare ACO plans could also allow it. They may not necessarily be rural. The other requirement that is currently not in place, but will go retro back, is the site requirement. So there's a geographic location, and then there's the place where they actually are. So this is a list of what are approved originating sites as of February 1st, I guess we should say. Those are going to be like your provider's office, a hospital, the critical access hospitals, all of those different places. A patient actually has to be located in one of those, and the patient's home is no longer a permissible site. That is where we are right now. At this point, the government or Medicare is not paying for telehealth provided in the patient's home except for specific types that have been permanently approved, which we'll go over now. So the only ones that are permanently approved for telehealth, to pay telehealth in the home, is if they're receiving treatment for substance use disorder, mental and behavioral health services, those now have new in-person visit requirements, or home dialysis for ESRD and diagnosis and treatment of acute stroke, but those only have a geographic exception, not a site exception. So those are the ones when, if you were paying attention to when CMS were sending out notifications and instructing the MACs to hold or pay claims, they were originally holding all telehealth claims except for ones they could identify as eligible for payment, which would have been these kinds of claims. Then just recently, they decided it was hard to identify some of those, so they started actually returning them or denying them, as we might see if you've been receiving those back on your Medicare payments. Okay, but again, all of that supposedly, if you have been submitting your claims or if you've been holding them and are waiting for the government shutdown to end, you should be able to submit those and they should all be paid from October, for dates of service October 1st and forward, all the way through January. So you've got, those should be okay for now. But as of the end of January, they also don't allow audio only anymore. It has to be a two-way interactive audio video technology for telehealth. They do have an exception for audio only if the patient's in their home. So if the patient's allowed to be treated in their home, those exceptions that I referred to, like behavioral health, and if the provider is able to use video, so you have that interactive audio video technology, but the patient cannot or doesn't consent to using video, then audio only is allowed. And that's permanent. That's not just with the telehealth waivers. But after January 30th, audio only would not be allowed for anything else. Right now it is. Well, it will be again. All right, so same thing, right? With the expiration of the waivers, certain provider types would no longer be eligible to provide telehealth. Those are your occupational therapists, physical therapists, speech language pathologists, and the audiologists. So right now they can't. As soon as the bill passes, hopefully tonight, and is signed by President Trump, either tonight or tomorrow, all that would be retroed, and any telehealth they had provided would be eligible again up through January 30th. Like we talked about with those behavioral health, so behavioral health, telehealth, the patient is allowed to be seen in their home, and that is a permanent extension of that. However, what would be coming back into play and is currently in place is that those behavioral health services have in-person requirements, meaning that the provider must have had an in-person face-to-face visit within 6 months prior to their initial telehealth visit. They do have kind of a little exception usually built into these expiring waivers that if they've been receiving treatment from you and it hasn't been face-to-face, then they kind of waive the 6-month one when these expire, but then you must provide the subsequent one, another subsequent in-person face-to-face within 12 months and at least annually thereafter. So in theory, they would extend that the next time if we fall off another cliff and those in-person requirements are reinstated, then you may not have to have had an in-person within 6 months, but you definitely will within the next 12 months. So you want to be aware of that. And a lot of this is to make you aware. So maybe we can all be a little more prepared if we actually fall off the cliff again, or if in the event we don't all fall off the cliff together and everything goes away like it did on October 1st, but they may make changes to what is allowed. There have been some bills introduced, and we assume there will be additional ones introduced after they reopen the government to approve these separate from the budgeting bills, the financing bills, so they would then become permanent. But what becomes permanent is always the question. The other things that expired and will expire again is the hospital at home model. A lot of you may be aware and have already had to scramble to, if you had patients in a hospital at home model and either had to move them back into your facility or actually transition their care to a different, maybe a SNF or something like that. And then the other one was the hospice recertification had to be face-to-face. So right now, once that gets reinstated, they're allowed to be done with telehealth. But if we fall off the cliff again, then they have to be done face-to-face. So those are the major ones that it's been a little bit confusing. So it all happened October 1st. It's currently not in place, but it will all be retroed back to October 1st and go through January 30th. So then we just need to pay attention what's going to happen after that. And it looks like we have a poll question coming up. So back to you, Brianne.
So our first poll question, how confident are you that your organization will remain compliant as waivers expire and the new rules take effect in 2026? We'll give everybody a minute or two to answer. Looks like we have a good mix of very confident and somewhat confident, which is great. These rules changing, you know, fast and furious are hard to keep up with. Some unsure. Okay, but most of the majority of the group feels at least somewhat, if not very confident about that.
Great. That is great, especially sometimes I wonder, I would ask my own poll back on that a little bit of, are we confident because we're pretty sure they're not going to expire? Or are we pretty sure because we're prepared if they do? And actually, if you're pretty sure they won't expire, that's not an unreasonable position to take, because most people agree that it's highly likely that at some point, most of these telehealth waivers will be permanently extended. It's kind of like we let the dogs out and they're not necessarily going to get rounded back up at any point. Everybody's kind of receiving healthcare in that way, and has been for a number of years now. So that's not an unreasonable place to kind of stake your flag. But we do also want to be able to prepare in the event either that they don't get extended or that not all of them get extended, and we are prepared, whether that's the in-person requirement so that we have the ability to have those in-person visits with our patients on at least an annual basis, or whatever other parts may not be included, to make sure that our practices are prepared to do that. So I'm glad that most people are feeling confident, and I think probably that you should. Okay, so let's go on to now our other telehealth cliff, which is kind of sooner than the January one. So December 31st, the end of this year, has its own kinds of telehealth cliffs. Most of them, luckily, are already being addressed, but there's a few that we'll want to be aware of, and most of them are through the physician fee schedule or other rulemaking. And that's the main difference between the telehealth ones that we've just talked about. Those are under congressional purview, so they have to be part of legislation that gets passed by Congress. These new ones that we're going to talk about, they are within the control of CMS or other rulemaking bodies. So under the agencies within the government, and they can't do anything that they're not authorized to do under law, but they do have the ability to adjust certain things that Congress has given them the authority to do. So that's a little bit of the difference there. So we had some things have been made permanent already, especially for behavioral health and substance use disorders. So marriage and family therapists and mental health counselors have been permanently approved as behavioral health telehealth providers. So where we had those lists of providers that if you fall off the cliff, they're no longer allowed to provide telehealth, these two types are permanently approved, just like an MD or an NP or the various others that are also permanently approved for the types of care they're allowed to provide. The other thing that is permanently approved is that those behavioral and mental health services can be delivered through audio only as long as the patient is in their home. So again, CMS, and to be clear, these are CMS rules. So this is essentially Medicare, what they pay for. And we'll want to be aware that commercial payers often have a little bit broader coverage for telehealth, but each one has their own. So you can't get into that all in one short presentation, each individual payers. And that's actually even true for your Medicare Advantage plans. So Medicare Advantage plans do essentially have to follow what Medicare does, but they were given, especially during this last shutdown, they were given some flexibilities to continue covering things even though Medicare didn't. So your Medicare Advantage plans will often be the same as Medicare, but they may also have some, they may also cover some telehealth that Medicare doesn't, if and when that changes. But anyway, on that topic, as far as the audio only, we would have to go back to, can the patient be treated in their home, which we know patients can be for behavioral health, can be treated in their home on a permanent basis for telehealth. Then if they're actually in their home, then they can do the audio only with those caveats that we talked about, which is that the provider has the ability to do the audio video, but the patient does not consent or doesn't have a device that would allow it. Okay, so the other things that have been in place is that there has been a frequency limitation. I mean, a frequency limitation has been suspended for in-person visits. And these are for your subsequent hospital visits, your subsequent nursing facility visits, and critical care consultations. So prior to the pandemic and these extensions and waivers, there was a rule that basically for these types of visits, usually it was every third visit had to be in person and it could not be by telehealth. Those limitations were suspended and have been, and would have come back into play on January 1st. But in our 2026 final physician fee schedule from CMS, they permanently removed those frequency limitations. So going forward now, there is no cliff for those in-person frequencies. So your subsequent hospital visits and SNF visits and all of those can be telehealth. There's no rule for when it has to be in person, except of course the quality of care rule, which is that it's the clinician's decision of when it is appropriate to provide care by telehealth versus when an in-person visit would be more appropriate for the patient's care. So that's some good news we got in the physician fee schedule, which dropped just at the end of October, actually Halloween night at it was probably like 7 p.m. or something like that in 5 or so in Washington is when that came out. So a lot of people are still kind of digging through that. The other thing is that virtual supervision is currently permanently allowed for certain types of incident to services. So this is where the supervising provider, so the service requires supervision, usually direct supervision by either the MD or the NP or PA, whoever is supervising the associate provider. But so it's only when they're incident 2 and it's a PCTC indicator of 5 or essentially like a 99211. So these are types of services where usually the provider isn't present anyway. Things like they come in and the nurse gives them a shot or possibly a blood draw or things like that. Those have been permanently allowed for a while now to have the supervising provider be available for virtual supervision, which is audio video supervision. With but the direct supervision to be allowed to be provided virtually would expire at the end of this year. And it's important to understand that audio only supervision has never been allowed when direct supervision is required. And a lot of this is for those of you if you want to bill incident 2 to Medicare, which is if you have either non-physician practitioners that you're doing with this or actually like nurses or MAs or anything like that, direct supervision is required and has previously required that the supervising provider be located physically in the office suite at the time of service, not necessarily in the exam room, but in the office suite. They have allowed this direct supervision to happen through an audio video technology pretty much since the pandemic was in place. They've also allowed teaching physicians to provide virtual supervision of residents for clinical care when the services are provided via telehealth. Those would be expiring at the end of the year. Again, this is another one where CMS has come through and made some of this permanent. So with the 2026 physician fee schedule, they permanently adopted their definition for immediate availability, which had said that they had to be physically in the office suite. They've now included that it can include real-time audio video communication technology for all incident to services under the regs, except global services or surgeries that have a global period of 10 or 90 days. So essentially those global surgeries where they feel like maybe the patient has a higher possibility of needing care more immediately. But everything else now, it allows for virtual or again, real-time audio video communication technology for your direct supervision. So for those of you who, again, if you're fully telehealth, that's good news for you. But even if you're not, it's good news that you may be able to have a provider. The provider can't be, performing surgery at the hospital because then they're not really immediately available. But as long as they're available to jump in if and when the rendering provider reaches out, then that can be done virtually. So that's kind of a nice one that we don't have to worry about anymore. The other thing is that they also permanently allowed virtual supervision by teaching physicians with your residents through your real-time audio video in the clinical instances when the service is also virtual. So this is not the case if the resident is in, either the hospital room or the exam room with the patient and the teaching physician is in another location. That is not what they permanently approved. It's just if the patient's in their home, for example, or in another provider's office, the resident perhaps is in their office and then the supervising provider is, at the college or something like that. So when it's a telehealth service, that is allowed for clinical instances. Otherwise, for clinical instances, it's not allowed. It is typically allowed for teaching, for educational purposes. So the teaching physician could be through telehealth for educational purposes. It's just not in those clinical instances that it's allowed. Okay, so more good news from the CMS physician fee schedule. The one that I know a lot of providers have been concerned about is that they were going to require providers to put their home address when you are actually providing telehealth from home. This is kind of an interesting one that I'm not sure we fully understand how that's going to work. In this new 2026 fee schedule, they did not explicitly extend the policy of allowing the providers to bill with their currently enrolled practice location when you're working from home, which is what they've been allowing all along. A lot of providers are uncomfortable, as many of us could understand why, with having their home address, because that actually can make it publicly available. But in this year, the 2026 physician fee schedule, they simply say that they did not feel the need to extend it, and they reference an FAQ that they had issued on how you can suppress a home address. So we're still trying to figure out exactly what that means if you do have to put your home address on there, but you can suppress it, or exactly how that's going to work. The implication in their response in the fee schedule is that the home address wouldn't actually be on there, but it's a little bit unclear right now, unfortunately. We'll see what we can find out. Okay. The other things that you may be interested in that are kind of telehealth related is your remote monitoring rules. In the physician fee schedule for 2026, they've added some new codes that you may really be excited about. Basically what they did is they recognize that sometimes you don't actually need a full 30 days of monitoring if you're doing remote patient monitoring or remote therapeutic monitoring. So they created codes that allow for billing if you only have 2 to 15 days of monitoring rather than every, which I think it was 20 to 30 in a 30-day period. So it was just an acknowledgement of how things are actually working sometimes in our practices, that maybe you don't need actually that many days, or the patient doesn't participate for that many days. They may not be compliant with the therapy or something like that. The other thing that is on that same vein is they created new codes for professional time in a calendar month for just the first 10 minutes. I think before that it was 15 or more had to be, or 20 or more, and you had to be able to bill for all of that, or you couldn't bill for any of it. So again, this is just an acknowledgement of the way things may actually be working in your practice, that you may only spend 10 minutes reviewing things and have one real-time interactive communication with the patient in a 30-day period. And they've opened it up to be able to allow for that smaller time period. Obviously, it's not going to pay as much as the longer one, but you at least have the ability to get paid for some of your time, even if you didn't meet the requirements of the previously existing codes. One thing I did want to mention, I know I said we can't get into specific payer policies, but wanted to put this out there because it's really interesting, especially from Medicare Advantage policy, is that UnitedHealthcare has announced that they are now going to only cover remote patient monitoring. They're only going to consider it medically necessary for two conditions: chronic heart failure and hypertension during pregnancy. They won't cover remote patient monitoring for any other conditions, and they've listed which ones they don't cover. The interesting part of this is that they have said that that is true for all of their plans, commercial, Medicaid, and Medicare Advantage. So it's interesting to see if this brings up, it could become a fight between, there's some discussion of, do the Medicare Advantage plans have to cover everything that Medicare does? And we know Medicare covers remote patient monitoring for these other conditions. UHC has said that they don't have to because there isn't an existing NCD or LCD in place for those conditions. So it's kind of an interesting legal position that may come up, but wanted to make people aware of that and to see how that might impact Medicare Advantage from other plans going forward. Okay, the other thing that you may be interested in is the conversion factor that comes out with the final rule. This is how much they pay, right? So we all know that they, and we'll see this in the One Big Beautiful Bill. In the One Big Beautiful Bill, they approved a 2.5% increase, a one-time 2.5% increase that was implemented in this final physician fee schedule. They also implemented a required QPP update, which is a plus 0.75% for participants of advanced APMs and a 0.25% for those clinicians who participate in MIPS or who are exempt from doing so. Again, that is statutorily required. There's a lot of people pushing back and saying it should be more for everyone, but right now that's what they do. An important thing to pay attention to is, depending on if you have facility-based providers, is the negative 2.5% efficiency adjustment and the 50% to the indirect cost component of the PE. So there's an efficiency adjustment that will be applied to certain non-time-based codes. So that's not going to apply to your E&M codes or anything like that. but they're saying that they feel like certain types of procedures that, you know, healthcare has progressed over time and they don't take as much time to perform, so they shouldn't get paid at the same rate as they used to because it gets done easier and faster. Who knows, maybe there's, you know, robots doing part of it, but that's their argument on that. And then the 50% to your facility-based services can be a significant impact on your hospitalists, your radiologists, those types of specialties where most of your services are provided in a facility. They are actually decreasing the practice expense RVUs by 50% for those facility-based services. So what you may find is that your 2.5% increase that was given out with the One Big Beautiful Bill may get eaten up with some of these negative adjustments that are coming out. So there are lots of tables and things out there that you can use to go and calculate if you haven't already. I would encourage you to do so, so you know probably what your Medicare payments are going to look like come 2026. And so many of the facility-based providers treat a large number of Medicare patients. So that's something you'll definitely want to look at. Okay, so the other part is, so this is not part of the physician fee schedule, it's separate regulatory, but there are certain things that are expiring as far as prescribing controlled substances over telehealth. So right now, up until December 31st, DEA registered practitioners can subscribe pretty much all controlled substances via telemedicine without having conducted an in-person medical evaluation, as long as, I mean, most of these are, right, they use interactive telecommunications, so they know who they're actually talking to. Obviously that it's for a legitimate medical purpose, that you're providing good clinical care and all of those kinds of things, that you have a proper DEA registration and all of those things. So that's what we're currently doing. So if you're performing telehealth and you're prescribing controlled substances, that's the what you're operating under. That is supposed to expire on December 31st. The DEA actually did issue, there's some permanent exceptions that will be allowed, and then they've issued some proposed rules that have not been finalized yet that we'll go over. So right now, a DEA registered practitioner can permanently, so doesn't matter if it's December 31st or January 1st, you can prescribe an initial 6-month supply of those controlled substances if you're treating someone for opioid use disorder through telehealth. And that includes audio only if audio only treatment is allowed, which we've talked about that already. After that 6-month supply, those practitioners, your telehealth practitioners, can continue prescribing either because they do an in-person medical evaluation or certain other types of telemedicine that are authorized by the Controlled Substances Act. So there are certain things, especially for your opioid use disorder treatment, that you can continue doing and it won't change. However, the other one that is permanently allowed is that Veterans Affairs practitioners can continue prescribing controlled substances via telemedicine, even if they haven't had an in-person visit, if a different VA practitioner has had an in-person visit. So that's specifically for our VA practitioners, but it's good to be aware of. Practitioners can also permanently prescribe controlled substances if you've had an in-person visit at some point with the patient, or if you're covering for another practitioner who has had an in-person visit with the patient. So this kind of goes back to those in-person visit requirements for behavioral and mental health. Then you can do those, or if the patient is currently in a DEA registered facility. So you'd have to be aware if they're in a facility, is it one of those that allows prescriptions via telehealth? So again, the proposed rule that they've put out is that what they did is they put out a rule that would create 3 separate special types of registrations for practitioners to continue prescribing controlled substances through telemedicine if there has not been any in-person medical evaluation. So in that rule, so you would decide which of those 3 special registrations applied to the way that you're providing care. And then there is a requirement on all of those special registrations that you would be required to implement specific requirements to mitigate the risk of drug diversion. The main one of those that they talk about is that you would have to check usually state registries for controlled substances. That's actually been one that they've gotten some pushback on because of the difficulty of doing that maybe in multiple states if you're seeing patients in states kind of all over the country. But that's the main one that but there's other ones too. It also requires any of you, the registrants, if you're registering as one of these special registrants, you have to have a separate state telemedicine registration for every state where you treat patients. So if you're seeing a patient in that state, you have to have this state telemedicine registration, which in many cases may already be required, may not be different from what you're doing already, but it's good to be aware of. The other thing that it really put in place is that it requires a different type of special registration for those online platforms that facilitate connections between patients and those telemedicine providers that will result in a prescription. So they're also trying to get a handle on some of those platforms. And a lot of this is because that's where they've found some of the bad actors have found some of the fraud or how their prosecutions coming that way. So that's why that became part of the rule. Again, this rule has not yet been finalized. So that's why we have the telehealth cliff at the end of the year for some of this prescribing by telehealth. So we'll see if they get around to taking care of that before the end of the year. And it looks like we have another poll coming up.
Right. So we're going to talk about audit exposure risk. How confident are you that your documentation supports your current telehealth E&M coding? So looking at results coming in, again, similar to our last polling question, it looks like most people are in the mostly or very confident. Although we do have about 25% of respondents neutral or are unsure, and maybe you're just not the right person that's privy to that information, but we're, you know, actually making sure that you do have the supporting documentation is always hugely important. So.
Yeah, great. And that's so true. And I think I love that you pointed that out, Brianne, that sometimes we don't really know until we have an audit, right? And we find out how good our documentation is. And there's so many parts that go into documentation. This one is specifically talking about our telehealth and our E&M coding and making sure that we've got the appropriate documentation required to support the telehealth services, especially with regard to those prescriptions of controlled substances. Okay, so now we go on to what were some of the healthcare provisions of the One Big Beautiful Bill Act and what kinds of impacts they can have on our practices. We already talked about the 2.5% increase to the physician fee schedule. This offsets the decrease that went into effect in 2025. So we've all been paid at that less than 2.5%. We're getting back to the rates that were paid in 2024, essentially, with this increase, but it's a one-time increase. It doesn't include any other future increases or decreases, except for the decreases that they put in the physician fee schedule. So it was nice that they put this in the big, beautiful bill. And of course, then CMS had to implement it. But we've seen that there's some other things that we have to be aware of. The main ones that are going to affect most of our practices is the changes to Medicaid required under the One Big Beautiful Bill. So those are work requirements coming into play, eligibility redeterminations, cost sharing, and limits to retroactive Medicaid coverage. So work requirements, as you're probably aware or have heard, is that there are now requirements on certain patients in the Medicaid population where they have to be able to show that they are either working or maybe going to school or certain types of caregiving. There are certain types of things that qualify under the work requirements to fulfill that. If they cannot prove that, then they will lose their Medicaid coverage. It also talks about increased eligibility determinations. So they're saying you have to actually redetermine a patient. Now, we don't necessarily redetermine the eligibility, the states do. Medicaid plans have to do eligibility redeterminations much more often than they used to. Again, the thought being that if they do this very regularly, it's going to be a large amount of paperwork for the patients. And a lot of it might not get done, so people might lose coverage because of that. So that's where that comes in for potential impacts. Cost sharing also comes into play for certain patient populations, that at some point there will be increased cost sharing, meaning co-payments and things like that for Medicaid services. I know in many states there's already some cost sharing in place, usually relatively nominal, $3 to $5 or things like that. This would be a little bit higher than that and only for certain types of coverage. But it would, again, it simply increases the need for practices to collect from the patients, where we typically haven't needed to worry about that with the Medicaid population. The other thing is that it limits that retroactive Medicaid coverage. I don't know how many of you experience this, but often we especially, I think, have seen it probably with facility-based providers, because so many of the health systems have really robust financial assistance, and they generally will, when a patient comes in, if they don't have any kind of insurance coverage, they will walk them through applying for Medicaid or different things like that, because they can anticipate a large bill coming due. But those now will not necessarily be retroactive to maybe the time of service that the hospitals may have. So that may adjust for you larger health systems with actual acute care hospitals. It may adjust that financial assistance policy a little bit. So, but let's say, okay, so how will this affect my practice? What are some questions you might want to know? So first, you need to understand which patients those new requirements and changes will affect. It generally only applies to Medicaid, the Medicaid expansion population. So if you work in a state where they expanded Medicaid under the ACA and other laws that have come out, then it's that additional, and typically the Medicaid expansion population covers working adults or even unworking adults, but adults that are kind of at a little bit higher level of the federal poverty level. It also affects unqualified immigrants. It actually changes which types of immigrants are qualified for Medicaid. So there are certain types of immigrants that have been qualified to receive Medicaid if they qualified on a financial end and their immigration status allowed them to get it. That it limited that significantly for whether certain types of immigration status no longer makes them eligible for Medicaid. So, but it's not going to include generally a lot of people that we may be seeing anyway, children and the parents of those children, generally under the age of 14 is what they look at. And then there's various other types. Medically frail is one that could be interesting. It's possible that certain types of behavioral health could qualify under medically frail, as well as substance abuse. Different types, medically frail can mean a lot of different things. So how that will affect your specific patient population, you'll probably want to look a little bit more closely at the details and at what your state Medicaid puts out. But it's important to remember that it's not everybody on Medicaid that's going to be affected by this. It's only really that Medicaid expansion population and certain types of immigrants. Okay, so that's good to know. So then now to figure out what do we do about this in our practices. So you want to figure out, okay, of my patient population, how many of them could be affected by these changes? And again, you're kind of guessing how many of them will lose coverage because of it. Maybe none of them. A lot of that probably depends on the way the state implements the law with those redeterminations. We saw this happen kind of when those redeterminations, eligibility redeterminations kicked in again after the end of the pandemic, and a lot of, it was a lot to do at once. So there was a lot of confusion amongst patients and Medicaid plans. But it'll be similar to that, maybe slightly more organized, but it'll really depend on how well, what your state learned from that process and how they're going to implement it. So again, try to figure out what portion of your patient population could be affected by this and how. Like, will they lose coverage? Or will they just have to start making cost sharing payments or things like that? And then you're going to want to forecast those financial impacts on your practice. How much of your practice is Medicaid? How much of that Medicaid percentage will be affected? And what could the potential financial impacts be? And then to prepare for this, which it does start, a lot of it starts either at the beginning of 2026, but a lot more of it kicks in through, they kind of have 2026 to get it all in place, and then 27 it really kicks in. But then you'll want to really strengthen your intake processes, which means you're going to want to have really strong eligibility verification to find out if your patient is on Medicaid at the time of service or not, or if they're maybe in flex. That's never a guarantee, but you want to at least make sure that you're checking the most current information, and also your upfront collection. So your intake processes, whether it's right at the front desk or you do a lot of it ahead of time, you want to make sure that you're doing that eligibility verification and that you're collecting, you have good processes in place to collect upfront if the patients have cost sharing or don't have insurance. The other thing is to make sure that you're optimizing your RCM process. You want to make sure that your entire revenue cycle process is as robust as it can be, so that perhaps you'll be stronger in some areas if some of the other areas under the One Big Beautiful Bill start to impact your practice. And again, not just the front desk, but your overall patient payment processes. You're going to want to make sure that they're as good as they can be, and a lot of that can be how convenient can you make it for patients to make payments? How clearly can you communicate that with them? And are you communicating with them in ways that they want you to? Do they want text? Do they want email statements? What are those various kinds of things? And then again, the various, can they pay online? Can they pay by credit card? And can they do a lot of that without having to get on the phone with you or come into the office? Then the last thing that you'll want to look at is, as I mentioned before, those financial assistance policies. One thing you want to look at, okay, if a higher percentage of my patient population is now uninsured than I had before, can my existing financial assistance policy support that increase? So it's not just the policy, but the potential that your policy will qualify a larger percentage of your patients for financial assistance or for discounts on their bills or things like that. You're going to want to make sure, one, that your process is really solid, and two, that the way that you have it set up is sustainable if you have a higher percentage of your patient population who is now uninsured or just has a higher cost sharing responsibility. So those are really good things to try to keep in mind. It's going to require a lot of in-depth reporting and data out of your system. So hopefully you can get that pretty quickly and conveniently and start to plan for these changes. All right, we have another poll question now.
All right. So again, along those lines of thinking about audits, how often does your organization perform an internal compliance audit or a risk assessment? So to Robin's point, all the things that she's talking about right now, if you weren't in the process or thinking about an audit, I think all of these items are things that probably are maybe pulling that up in your schedule, or maybe making it where you want to add some additional audits. A lot of people are responding that they do an annual audit, and then nice to see some doing quarterly or twice a year. With all these changes and moving parts, it might be a good time to look at to see if you want to do some more focused audits that are more frequent than annually.
Yeah, that's great. It's like I said, this is why we're never bored, is because something's always changing, but it keeps our lives interesting. And that's why we want to do, if not a full risk assessment or audit, we definitely want to be reviewing where we are with what might have changed in the last month or 2 months or 6 months or whatever. So that's great. Okay, a few other things that we're going to bring up. Prior authorizations is one that comes up quite a bit in our practices. Most of us, if we have to deal with them, they're kind of a necessary evil in some ways. And they can be quite a bit of administrative work. You may have people that that's all they do all day long is do your prior authorization. So there's a few changes potentially coming up. The main one that we want to make sure you're aware of is what's called the WISER model. And this is a new one from CMS. They are implementing prior authorization for certain office-based or outpatient services. So historically, Medicare, CMS, has had very low amounts of prior authorization required for anything, and pretty much all of it was for inpatient type services. But they're putting out this model called the WISER model, which is for wasteful and inappropriate service reduction. And it's only in 6 states starting January 1st. It's only in 6 states. So if you're in these 6 states, you may want to pay attention. And it's supposed to run through 2031. The states may change, and what they're requiring authorization may change throughout the model, but this is how it's starting out. So it's in just those 4 MAC jurisdictions, which are located in those states. So again, be aware of what your MAC jurisdiction is. This is what they're calling you have voluntary participation, which essentially means you can either submit your pre-authorization request up front, or you can go through prepayment review. So you can either go through the prior authorization process, or they'll come back and ask you for the documents anyway. So again, actually submitting a prior authorization request is voluntary, but sending in your records is not going to be voluntary under this model. And a big part of this model is that they are hiring certain companies with the idea of them implementing technology like AI to really streamline the processing of prior authorizations. And those companies which have just recently been announced, they receive a percentage of the savings gained through that enhanced technology. Not necessarily the savings gained, it's not totally clear, but not really the savings gained through, for example, denying services, but really just through the really hopefully making that prior authorization process relatively seamless and quick. So it'll be interesting to see how they do that. And then just again, so it's right now they're only putting 14 services on there, which looks like a lot, obviously, but it's only, again, if you're in those 6 states, in those Medicare jurisdictions, and you are providing any of these types of services, then you will be subject to the WISER model. That may change over time. There was one that they said they were going to put in, deep brain stimulation, which they are holding off on doing right now. So again, these 14 services may change over time. We actually had a meeting recently with someone at CMS who kind of explained in many ways that a lot of this is because many of these were areas where they had found fraud happening more often, not every single one, but that a lot of this is to address fraud that they have already identified in the system. So it's partially to make sure that the services are, of course, appropriate for the patient, but it's also I think they're also hoping to kind of weed out some of those bad actors out there. So really important to be aware of if you provide any of these services in those 6 states. And it's a brand new thing. Really, Medicare has never done prior authorization for outpatient services. The other main thing that probably a lot of us have heard about is that the private insurers actually issued a prior authorization pledge. They all came together, well, I don't know all of them, but most of the major ones came together and stated that they were going to try to standardize all of their prior authorizations electronically using FHIR APIs, which in theory could pull data, would work with your EHR to pull a lot of the data needed for prior authorization. Again, the theory being it would decrease the administrative burden of those PA requests. They pledged to reduce the use of prior authorization. Part of this, they've talked about kind of what some people call a gold card program, that if a provider, always gets their stuff approved because they're always doing what they're supposed to, I guess, or at least providing the right documentation, then they may allow them to not have to get prior authorization on certain things or as often. They're promising real-time decisions, up to 80% of those electronic requests, and improved communication. So a clear explanation of if they deny a PA request, why that's being denied, and clear guidance for how to appeal that denial. This all sounds fabulous, and we're very hopeful that it comes about. We do have to throw out the caveat that many of these insurers have made similar pledges before. They're responding, I think, to the moment where prior authorization is talked about quite a bit, but we'll see what happens. And we certainly are very hopeful. And I do really think they're going to try to make things electronically much simpler, and AI and different things like that should assist in that process. So we'll see. And finally, with Medicare Advantage, you may have heard that that CMS has talked about doing increased oversight of the Medicare Advantage plans to make sure that they are operating the way that they're supposed to. The main one is they're going to do that by expanding their auditing of the Medicare Advantage plans, which they've said now they will now audit all eligible Medicare Advantage plans, which previously they only did a few of them each payment year. So they're going to do all plans every year, and that they're going to audit a larger number of claims. And that's a lot of this is where, if you've heard about them saying that the Medicare Advantage plans, they get paid a certain amount extra if they can show that the patients they're treating had really complex conditions or certain diagnoses, things like that. And there's been some claims that was being done by AI and maybe making stuff up or something, who knows. But that's partly why they're increasing the audits of these plans, is to make sure that that's not happening. And then they introduced a plan to complete any open MA audits. So they haven't even gone all the way back to 2018. So they have a plan supposedly to finish auditing of all these plans and all these claims through 2024 by the first part of 2026. And then they'll do it again every year going forward. So why do we care? If you're not a Medicare Advantage plan, because the likelihood is that if they are getting more audits, they are going to audit the providers more often, because they want to make sure, right, that the medical records do support what they are submitting to CMS. So we can anticipate increased medical record requests, increased claim audits, both pre and post payment, and increased scrutiny of the diagnoses that we're submitting. So you just want to be aware of that. Again, we talked about audits and whether we're comfortable with our documentation. You want to make sure that all of that is good and that you have staffing in place to handle potential increase of requests on those things. All right, we've got another poll question.
All right, so our last poll question today: which compliance areas worry you most for 2025 and 2026? So Medicare geographic, originating site rules, documentation and auditing risk, which I could see is already a big one, and after listening to what I just heard, I'm worried about it. remote patient monitoring, DEA, telemedicine prescribing. So definitely always documentation and audit risk is always top tier. So no surprises there.
No, no surprises there. And it's reasonable because again, I think the more the health plans tend to be scrutinized, the more they scrutinize. So it just kind of goes back both ways. All right. And we're ready for questions and answers, hopefully.
Yeah, so if you do have any questions and you haven't submitted them, you can put them in the chat with the question mark. Robin, I do have a question for you. So on the audits and CMS looking at Medicare Advantage plans and that potentially increasing provider audits, do you think that there's anything that CMS may find where those Medicare Advantage plans are actually denying things too aggressively and maybe those audits kind of go the other way?
Well, what they're really auditing is so the Medicare Advantage plans submit reports to CMS every year, basically, that kind of and as a result of this reporting, CMS pays them additional money. So they get allocated a certain amount of money, right, to pay for the treatment of the Medicare Advantage patients. But then they submit this reporting and CMS pays them additional money because, again, maybe their patients were super sick and different things that maybe weren't taken into account with the initial lump sum that they were given. So that audit is of that reporting. It can, but in order to substantiate the data that the Medicare Advantage plans have submitted, they have to look at the provider records. So they're not, and this was actually made clear in our last meeting with one of the CMS officials that we had just a week or two ago, that they're not actually looking to make sure that the Medicare plans are doing what they're supposed to as far as paying providers, not denying under prior authorizations. That's not their focus right now. It doesn't mean it won't come around, but that's not their first focus. Their first focus is to make sure that the Medicare Advantage plans are transparent and accurate in the reporting that they're sending to CMS that results in additional payments.
Thank you. That's great. So another question, and I know on the Panacea side of our business, it's something that comes up with the clients. So the API with insurance companies, right, allowing their reviewers to just have access to your EMR. Can you comment on any risks, benefits, or maybe just give an educated opinion if that should make things easier in the long run for a provider to not have to pull and submit, records with claims and having that process delayed? Do you see any benefits or risks for anybody who might be hesitant to allow that?
Yeah, and that is a complicated one because it's one of those that sounds great in theory. I think there are some risks in practice, and a lot of this actually comes from some studies that have been done of the amount of inaccurate or incomplete information that can be found in EHRs. And that's not necessarily the provider's fault. It's just kind of, there's a lot going on when we're in the middle of treating a patient and trying to document that. So part of the risk is that what those APIs pull is incomplete or inaccurate, and therefore doesn't work, obviously, to support what you're requesting a prior authorization for, or different things like that. So, and a lot of the other main issue that a lot of people have brought up is the communication between those two systems, between your EHR and however the health plans are going to try to pull that data. Because right now, if you have experienced this, that sometimes and the same EHR in different facilities don't really communicate with each other. So that type of communication is at the moment a little bit of a pipe dream, yes, but it's not impossible. Lots of things, AI and things are moving things forward so quickly and automating so many things that, we've just been doing ourselves for so long. But there are definite concerns that you would want to be aware of. And a lot of that is just making sure that your EHR, that you're using it to its fullest benefit, and that you're doing it in a timely and accurate manner, which you should do anyway, but it's really hard.
Yeah, thank you. You answered my question that I was thinking of, is how do they know where everything is in your specific medical record? Like, are they grabbing the labs from the right place? Are they looking at the right note or information, and how do they know where to go get it? So thank you for that. Well, that
Okay.
takes us right till 2 o'clock. If there's any other questions that we didn't get to, we'll take a look and send you an answer back. There is a copy of the presentation available, and you will get a link to a recording again. And if you have any issues with CEUs, please let us know. But thank you very much for your live participation. We really appreciate it. Have a great day.
Thank you.